Coming to complications of tuberculosis, parenchymal complications include patient may go into ARDS where the patient may have a respiratory failure, not responding to oxygen therapy. Cavities which are present may be infested by a fungus leading to a fungal ball or aspergilloma. Sometimes the patient may have complications of multiple cystic lung lesions and extensive lung destruction and cicatrization. Mediastinal complications include fibrosing mediastinitis, constrictive pericarditis. The heart may be involved. Esophagobronchial fistula, where there is a connection between the esophagus and the bronchus, and esophagomediastinal fistula. The airway complications include bronchiectasis. Patient may have bronchiectasis, which includes bronchiectasis, nothing but one or more dilated bronchi, which is permanent, and broncholithiasis, where the patient coughs up stones, calcium stones. Bronchostenosis, where the bronchus becomes stenosed or narrowed, and bronchiolitis obliteralis. Pleural complications sometimes include a bronchopleural fistula, where there is a connection between the bronchus and the lung. A hydropneumothorax, where there is fluid with air in the pleural cavity. So for this, the treatment depends upon, you start the treatment anti-tuberculosis medication early, and you have to put an ICD drain or intercostal tube drainage, which may be required, or depending upon the response of the patient on ICD, or a VATS, a surgical procedure, video-assisted thoracoscopic surgery. It's a minimal invasive surgery which may be required if the patient is not responding with intercostal tube drainage. Patient may have fibrothorax, where the lungs are fibrosed, there is volume loss of the lungs, and patient may have a pneumothorax, which is nothing but air in the pleural cavity, and patient has to get an intercostal tube drainage done. Or an empyema. Empyema, where pus is present in the pleural cavity. And same, we have to have some surgical procedures for the patient. Vascular complications include bronchial and pulmonary arteritis and thrombosis. So pulmonary embolism may also occur as a complication of pulmonary tuberculosis, where patient may present with hemoptysis, chest pain, breathlessness, and bronchial artery pseudoaneurysm, where there is dilatation of few blood vessels. Pulmonary artery hypertension. So pulmonary artery hypertension may occur due to hypoxia, or when the patient has breathlessness. Chronic breathlessness may lead to pulmonary artery hypertension. The chest wall complications include chondritis, empyema insistence, where the pus in the pleural cavity, if not drained adequately, may rupture and come out through the chest wall, which is called empyema insistence. And other complications of chest wall may occur, like spondylitis and osteomyelitis, inflammation of the bone. So these are the various complications that may occur due to tuberculosis. So basically, starting the treatment early in a patient with tuberculosis will help the patient to recover at a faster level, and adequate nutrition should also be advised to the patient, because previously, before the chemotherapeutic era, tuberculosis was only treated with good nutrition, whereas after the advent of anti-tuberculosis drugs, now we are giving drugs to everybody who have been diagnosed with tuberculosis. Even now you can even give drugs to prevent tuberculosis. So the various drugs which are used are rifampicin, isoniazid, pyrazinamide, and ethambutol. And you also have multi-drug resistant tuberculosis, where the tuberculosis does not respond to the conventional anti-tuberculosis drugs. So for MDR tuberculosis, you have an MDR regimen which can be extended up to 1.5 to 2 years. So adequate nutrition should be provided to the patient, and the outcome of the patient should be decided clinically. We have the outcome of the patient should be decided clinically. If we come to know that he is responding, so improvement in his weight will occur, improvement in his clinical symptoms will occur, and he will become clinically stable, his respiratory symptoms will come down. Any patient with tuberculosis usually tends to become tuberculosis spreads to droplet infection, but once the anti-tuberculosis medication is started, so usually within 2 weeks the patient's respiratory droplet load becomes less, so he does not transmit the disease much, so he can be treated as a normal person. He can go anywhere, roam anywhere. But especially, we advise any patient with tuberculosis to maintain respiratory hygiene, because even in his house, to prevent the spread of tuberculosis to others residing in his house, especially the pediatric population, they are more vulnerable to tuberculosis. So they can get tuberculosis from their parents or anyone who has been infected with tuberculosis. So to prevention of tuberculosis, usually we advise all patients to have a good nutrition, a good hygiene, a respiratory hygiene, and nowadays, BCG vaccination is being given in India, especially at birth, because in India, where tuberculosis is a very high burden disease, it will prevent patients from getting severe forms of tuberculosis. And the other things involved with the treatment of tuberculosis include regularity of treatment. Since the course is for 6 months, patients tend to not take the medication continuously. Some may, default the medications. So it depends upon how well he takes the medicine. So nowadays we have NTEP, National Tuberculosis Elimination Program. So they take care of the patients. So once any patient is diagnosed with tuberculosis, we usually get them involved with NTEP, and so that they are being monitored on how they are taking the medication. So regular intake of medication is also important for treatment of tuberculosis. There are a lot of defaulters or patients who quit medication after 50 days or 1 month or whatever. So in patients who do not take the medication regularly, they are at more risk of multi-drug resistant tuberculosis. So that is why, to prevent even MDR tuberculosis, regular intake of drugs is also required. See, and the other strategies which are very important in treatment of tuberculosis include any cough of 2 weeks duration should not be neglected. A lot of patients tend to feel that by just taking some out-of-the-counter medication, the cough may come down or something like that. So it is always advisable to examine yourself if you have a cough of more than 2 weeks duration, so that at least a basic investigation of a sputum smell microscopy or a chest X-ray can tell us whether you have any tuberculosis or any other form of respiratory illness, for sure. So to prevent all this, usually we advise all patients to get themselves tested if they find that they have any constitutional symptoms also. Fever, as we discussed, constitutional symptoms of fever, loss of weight, reduced appetite, so all these. So all patients who are having these symptoms or want to get themselves tested can come and meet me at Atreum Hospital, and we can get them tested. If there are any questions, I would like to answer.
It is not treated, what will happen for 6 months?
Patients who do not take medication regularly
Okay.
will end up with complications of tuberculosis. First of all, they may get multi-drug resistant tuberculosis.
Okay.
Since if you do not take the medication regularly, first of all, complications like what we discussed, suppose a patient with pulmonary tuberculosis, he can end up with pleural complications, he can end up with other complications, the disease may spread to other forms, and he may become a chronic form of tuberculosis.
Okay.
And if this continues, where he is defaulting the medicine regularly, it can end up with multi-drug resistant tuberculosis also. So it is advisable that the patient takes the medication regularly.
Is the tuberculosis curable, doctor?
Yes, definitely.
Okay.
Tuberculosis is curable. If it is drug sensitive, 6 months of therapy is appropriate.
Okay.
And if he takes it regularly, definitely it is curable. Usually when you suspect tuberculosis and you don't have any other findings, MON2 test can also be done to detect if you have any latent tuberculosis infection. So MON2 positive will also give us an idea whether you have tuberculosis. But in this scenario, in our scenario, in India, usually where there is a high load of prevalence of tuberculosis, MON2 does not help us much, but it will help us in scenarios where we are suspecting tuberculosis, but we are not, all the specimens are negative. So on some basis we have to start tuberculosis medication. As a trial therapy in those kind of patients, we can get a MON2 done and start a trial therapy. But MON2 test will definitely help in the pediatric population.
Okay. Doctor, where are available in Rajagopal?
You can come and consult me in Atreum Hospital.
The timing, doctor?
Timing depends upon you consult the hospital people, they'll tell you the time.
Okay. Doctor, in our daily life, how do we adapt to prevent the tuberculosis?
A good nutrition,
Okay.
a good diet, healthy lifestyle will definitely prevent you from getting tuberculosis.
So nowadays in the paper they are giving that COVID affected patients also will affect the tuberculosis patients. Is it true, doctor?
Yes, a lot of COVID patients have been, post-COVID patients have been diagnosed with tuberculosis in the post-COVID phase. Maybe because their immunity levels had come down, they would have got infected with tuberculosis. But coming to the actual scenario, during the COVID phase, where everyone was wearing masks, there was reduced transmission of tuberculosis. Actually, if this continues, we can reduce the transmission of tuberculosis also.
Thank you, doctor.
Thank you.